Pregnant trauma patients and trauma patients on blood thinners are eligible. TXA is now going to be given as a weight-based dose at 15 milligrams per kilogram to a maximum of 1 gram over 10 minutes. Remember, you can put it into a 100 ml bag and run it in that way. Treat early. Remember that we don't want to treat anything that's more than 3 hours old. Contraindications and allergies greater than 3 hours since the event, known allergy to TXA. Side effects, if given too fast, are still going to be hypotension and seizures if too much is given. So for paramedics, again, patient over 5 years of age who has a systolic of at least 90, heart rate of 110, or if we determine that it's a high-risk patient, we can administer TXA 15 mg per kg to a max dose of 1 gram IV over 10 minutes. For patients under 5, we can contact medical control, and they may advise us to administer the TXA in that patient population. Okay, getting back to the protocol changes. Protocol 5.2, difficult airway. Added language in the paramedic section in C under to facilitate intubation. So section C, if the airway is unstable and the patient cannot be ventilated, if approved under protocol 6.2, needle crike, perform a needle crike. Currently, we are not using needle crikes. We will be doing surgical crike training, however, in the near future. Next change is going to be protocol 6.0. Under the medical director options. So they did a title change, BLS bronchodilators, adult and pediatric. New title, check and inject by EMT basic, protocol 6.6. New title, continuous positive airway pressure, CPAP by EMT basic and or EMT advanced. And then new protocol, glucagon for hypoglycemia by EMT basic providers, protocol 6.1. Moving down to protocol 6.1, here's the title change. You'll also notice that within this protocol change, they've added a new medication, ipratropium bromide, also known as Atrovent. So EMTs are now going to be carrying Atrovent. Oftentimes the top of the packaging, which is on albuterol, is normally blue. On Atrovent, it's normally green. We have to be careful with this, though. Because from time to time, the racemic epinephrine packaging is also green. So everybody needs to be very thorough in making sure that they follow their 6 rights and check the appropriate medication that is going to be administered. Ipratropium is works as an anti-muscarinic, so it helps to do some bronchodilation, also helps to kind of dry up a lot of the mucus that can be involved. So it works really well in pretty much all patients, but it works synergistically along with albuterol, meaning that it's going to kind of amplify the effects. My recommendation is that if you're giving an albuterol treatment, you should be adding the Atrovent. And that now is going to be part of your protocol. There will be a 30-minute additional class that you will need to take just to familiarize yourself a little bit with the protocol and also the medication. Just to review, the adult dose for ipratropium is going to be, make sure I'm in the right section. 250 micrograms via nebulizer for the pediatric and 500 micrograms via nebulizer for the adult. So 0.5 milligram is the standard package dosing that we carry. So for the pediatric population, you would make sure you just give half. So it's pretty consistent with the albuterol as well. You either give a whole for an adult or a half for a child, the age of 2. Moving to the next protocol change, selected spinal assessment, protocol 6.3. This is another protocol that we are going to be adopting. There will be additional training that we all need to take. the entire agency to familiarize ourselves with the flowchart and the requirements. So on page 3, the yes arrow was reinserted from patient unreliable to immobilize. Red flag and caution box has been reinserted, so they're just referencing down here in the flowchart. This protocol is going to allow us to be more selective with who we put collars on. The flowchart, if you follow it to a T, it's going to give you the appropriate recommendation of whether or not you should apply a cervical collar. Most importantly, anybody who's age 65 or older automatically gets a collar. They are not able to fall into this flowchart at all. So, mechanisms of injury: axial load, blunt trauma, motor vehicle crashes, bicycles, fall greater than 3 feet, adult falling from standard height are kind of the basis here. Age 65 or older, if the answer is yes, but they are 65 or older, we're going to automatically put a collar on. If the answer is no, we move down to the next box. Is the patient unreliable? So, do they have a GCS of 15? Are they alert and oriented times 4? Answering all questions appropriately. If the answer is yes, they are unreliable, we immobilize. If the answer is no, we move down to the next box, which is distracting injury. A distracting injury, again, would be something like an open tib fib or open femur or something that is very distracting to you. If the answer is yes, you immobilize. If the answer is no, you move over. Abnormal sensory exam and motor exam. So this falls into our CSMs. So circulation, sensory, and motor function. Remember that pre and post collar application, we should really be assessing all 4 extremities for this. Things that we're checking for are you able to wiggle your fingers and or toes? Are you able to follow simple direction? Are you able to feel in different aspects? So make sure you are checking one extremity at a time. If you touch both of their hands at the same time and they are unable to feel in their left hand, they may not realize that they can't feel you because they can feel you touching on the other side. So make sure you're touching each extremity individually. And then the circulation, we always want to check for pulses. So check for radial pulses, brachial pulses if need be, depending on where the injury may be. In the legs, you can check for popliteal. You could check for pedal pulses. Wherever the extremity is will determine where you're going to be assessing for circulation function. Alright, we are also going to be trying to come up with a efficient way to put this onto a card so that we can keep it right next to our badges to quickly reference on scene while we're all getting familiar with this protocol. It's also going to help us reduce some costs by lessening the amount of cervical collars that we put on patients that are not being returned so that we can use them again. Next protocol change, again, talks about TXA. We did already cover that, so we'll move on to the next one, going into protocol 6.6, which is the check and inject epinephrine for the EMT basic. Title change from BLS provider now specifies EMT basic. Again, they're just trying to standardize the language across the board so that all the protocols are very consistent. Move down to the next one, protocol 6.9 for CPAP. Again, for consistency, they changed it to EMT basic from BLS provider. And the hyphen has been removed from EMT and basic. Going to the next new protocol, glucagon for hypoglycemia by EMT basic. Glucagon by basics if approved by medical director. So it has been approved for us. Now we just need to complete the education. Once we have 100% compliance with the education, we'll be able to implement this. That means that we're going to be putting a glucagon kit together. Dan and I will be looking at the best way to do so, and we're going to figure out how to put a small kit together, whether it's using a small case like the old EpiPen cases, or using something similar to our check and inject eyeglass kits. We will put all of the supplies needed into each one of those kits so that the medications are not just rolling around. Next change, we're moving down to the appendixes. There we go. All right, and we're going to A1. So, ipratropium bromide. Here we are. Ipratropium bromide dose of 0.25 milligrams if under 2 years of age has been added. And that now reflects the dosaging for pediatrics along with the BLS albuterol protocol. Looking at TXA, noting again that it's a medical director option for this, as long as we are trained. The dosage is again changed from 1 gram over 10 minutes to the new weight-based dose of 15 milligrams per kilogram to a maximum dose of 1 gram IV over 10 minutes. So we're going to have to do a little bit of math now when we administer the TXA, and we're again going to be putting it into a 100 ml bag and giving it over 10 minutes. The next change, A2, pediatric medication reference. Versed dosing has been since adjusted to reflect the midazolam dose change in protocol 2.15 pediatric seizure and pediatric and the previous protocol changes. So let's quickly look at so within this pediatric color-coded appendix, the Versed dosage is now consistent with the protocol change for Versed. So you can see here for the blue color, Versed is going to be 2 milligrams. In the orange color, see it again, 2.7 milligrams. And then if we just jump back and reference the protocol 2.15 for pediatric seizures, our dosages have changed. It's 0.1 milligrams per kilogram to a maximum single dose of 8 milligrams if giving it IV-IOIM. If we're giving it nasal, it's going to be double that at 0.2 mg per kg to a max dose of 10 milligrams. And last but not least, the final change under the IFT scope of practice is going to be, so this is in regard to the PCA pump transports. So under section A here, routine scheduled transport, patient truly stable for transport with no requirement for airway management and no device in place that is actively running or requires any maintenance or monitoring. Patient may have a device in place but must be locked and clamped, not require any maintenance, and not be actively running. Such inactive devices may include, but are not limited to, IVs if disconnected from fluid, saline lock, NG tubes, feeding tubes, PICC lines, bladder irrigation, wound vacs, that are self-contained, gravity draining, or battery powered can be transported by BLS providers. Running PCA pumps are not inactive. For acceptance, see below. This is the level of care needed for a patient with any device that will not require active intervention or management by BLS unless ALS is otherwise required for patient management. The device is managed by the patient or accompanying caregiver. The patient or caregiver must have been trained in managing the device, not merely in its use. The example, the patient or caregiver must have the knowledge and ability to stop a PCA pump if the line is damaged, minimum staffing, BLS license, ambulance services. So as long as the patient and or caregiver are trained in how to stop the pump, these can now be transported again by BLS providers, just like they used to be. Otherwise, an ALS provider should be in the back in case the pump malfunctions and you need to turn it off. Now for the quiz.